Anand, it's
Yeah, I'm ready. I see my presentation here on the laptop.
exactly. Yeah.
All right. Thank you so much for allowing me to be a part of the session. I decided the most important part about the post-refractive eyes and corneal procedures is actually getting the K. No financial disclosure, but it would be nice to have some. Uh, I guess getting a accurate K is like achieving nirvana. Once you get that and you're happy with the results, you're almost sure that you would get majority of the part right. So I'll start with this one of my patients. They're in the business of government contracts, diagnosed to have at another hospital, and history of RK done for a myopia of -8 in both eyes. Her children are doctors. Her son is a clinical trial specialist. He's done intensive research on the types of IOL and me. And he's read all my papers published. He has a discussion with me on my PCR rates, number of premium IOL surgeries done, and son also discusses the average post-operative results, including the confidence intervals. Now, the doctor then decides that she wants to come in and observe surgery, and the patient's preparation is a standard pre-op preparation, which included eye drops, which is antibiotics and NSAIDs. My pre-operative preparation include prayers to all the 33 million gods that we have. Luckily for them and me, the surgery went off perfectly. And this is the pre-op. You can make out the RK cuts quite deep, and we planned the incision for the cataract based on that. Luckily, we were lucky with the topography that we could actually get a reasonably regular astigmatism, and we planned for a surgery based on that. Post-op, the results were actually quite good. You can make out the cuts do come a bit into the visual axis, so this is important when you're planning the positioning of the IOL. At the end of the day, the hospital were happy with the income, and I was happy with the outcome. When you do a PubMed search at about 5:30 today, I found that there is a very significant amount of published articles, and this is something that's probably going to go up. Now, when you're getting the IOL power, especially for these set of eyes which are post-refractive surgery, keratoconus, ectasia, keratoplasty, or post-RK, it's important how well we actually do in these situations. How well we do in normal eyes, I think most of us would be between 80-90% of about 0.5 of the target, and with the present formulas, most of them now available online, it's actually quite good. Uh, but in patients with excimer surgery, and there's a report by AAO, how accurate are we? And there are multiple sources of errors. One is, of course, the axial length, the keratometry, and the effective lens position. These are important factors in each eye, especially in these eyes which are high myope, with probably sub changes in the zonular positions, they tend to vary. When you have a patient with previous RK, PRK, or RK, you need to have basically to look at the ablation profile. So topography especially is important to check what is the way the ablation is being done. There are of course multiple biometers, and all of them have different amounts of measurement in the central part, and they tend to overestimate because of this central flattening. So definitely look for small optical zones or for decenter ablations. There is, of course, a change in the anterior and posterior corneal curvature. And usually the standard refractive index, which is about 1.3, is used for this assumed keratometry. So this changes, hence your keratometry amounts will also change. There is, of course, a second part, especially in high myopes, where we know that the zonules and the bags tend to be not within the normal limits. That's why the effective lens position changes. So most of these IOL prediction formulas use the keratometry and the axial length to estimate the effective lens position, which is basically an estimate, hence not very accurate. So you need to understand that you're not aiming for a 100% result. If you get about 80% within about a diopter, not 0.5 for normalized, but about a diopter, you're pretty good. Now, when you have multiple ways to measure K, which one do you actually choose? Because there is a very, very wide variety. Manual keratometry, if you're actually good at it, for normalized, it works well. For slightly irregularized, takes a bit of practice. But since we were trained on this, I know that they tend to give fairly good results. Auto K, not a bad start, is what I would say. If you want me to give marks, probably about 80 out of 100. But the other present IOL masters or the lens stars, where you have multiple points of measurement, is actually a good idea. So corneal imaging probably the best because the number of data points goes up dramatically from about 10,000 to about 25,000 depending on the type of machine you use. You have Placido, Scheimpflug, OCT based which are true case, and now in a hybrid in terms of eye trace. And if you're in a private practice and you want to use the machine for multiple uses for treatments, usually the first two would suffice quite dramatically. There is something called the EKR in Pentacam, which measures the central keratometry across the range, which is normal, LASIK, and RK. So if you can see, the average over a 4 millimeter zone for a normal patient is between 41 to 44, which is actually quite good. But for a LASIK and an RK, the spread is actually huge, especially if you look at RK, it varies from sometimes 32 to about 45. So what is the zone that you need to take? Now, there has been some studies based on what would be the ideal zone, and usually a 4.5 may not be the exact. You may need to take slightly smaller zones as the point of reference. So I prefer to take between 3.5 to 4. Now, corneal topography probably a more reliable tool because you have a larger diameter of measurements. You have the EKR in Pentacam, you have SIMCase, you have TKR, a total corneal power, and IOL masters, and there's something called TMP in OpScan. So both, all of them I have used, all of them I feel give fairly consistent results. You can then plug these keratometry in on online calculators, and we are lucky to live in a generation where you have access to all this at no cost, and these are free. You can get them, and I've used all of them. I find them to be actually quite accurate, not much variation in the websites as well. This is just an example of how you would actually look at it. Now, if you have the IOL power calculation, it gives you basically with no prior data, or you have some prior data, it gives you an average with a max and minimum. So that part is your clinical decision. How much do you want to aim for? Which formula do you believe in? Our experience says that if you have a combination of OCT measurements, a Pentacam or a Scheimpflug based keratometry, you would be almost about 90% in terms of being on the right side of the power. Now, there are, of course, multiple studies also published on the calculation power, selecting the data. And I think, as I said, 80% within 0.5, 90% within a diopter, you're quite good. The True K formula was something that has come in over the last 10 years. And I find that True K, especially for training the optometrists, is actually a very, very good idea. Post RK corneas, as I said, slight change, doesn't fit into the normal parameters, but the results with the IOL power online calculators has been actually quite good. There is one subset which we are started seeing a lot more of keratoconus patients, which can be basically eccentric cones or central cones, or at least a regular part, some part of it having a regular astigmatism. The points to keep in mind is the visual axis, the steep keratometry, and the position of the cone. Remember that mild may still be happy with wearing glasses. Toric IOLs, if you have a regular part of the irregular astigmatism, you can still use. And if they are already wearing RJPs, maybe a good idea not to use toric IOLs. Aberrations is something that we have done work on. I won't touch upon it, but broadly remember that they would have a bit of glare and halos even after surgery. And if you have grades of keratoconus, from good, the tolerability in terms of repeatability and for all the imaging is good for mild to moderate. For the severe cases,
Dr. Anand, can you summarize?
Last tends to be worse. In terms of the generation formulas, the fourth generation formula is probably the best. So in terms of modern cataract surgery, the talk about AI is probably more the person, which is more important. The man behind the machine is a lot more important. So in conclusion, you need to counsel the patient for suboptimal outcomes, be aware of the sources of the error, use online calculators, and remember that there are some eyes which may not fit into your 100% result. Thank you so much. Acknowledgement for a couple of people who helped me with the slides. Thank you so much.